just as a warning, as you can kind of see, the images are kind of graphic, so if you're squeamish, you might want to shut your eyes. Please don't throw up. So here we go. Alright, so we are Team Legs. Our official team title, our research project, is the effect of tensile strength loss on collagen organization and anterior cruciate ligament grafts post-reconstruction surgery. But we just go by Team Legs. Before we begin, we'll take a quick moment to introduce everyone. So at the end we have Jenny, Pyle, Vicky, Kelly, Rupal, Ayushi, Matt, Kelly. I'm Ben, Joey, Alicia, Tina, and Yasi. Alright. So most of you are probably familiar with the ACL. Just a quick review. It's one of 4 main ligaments in the knee. It's located in the middle and it attaches the femur to the shin bone, provides stability in that sense, and also provides some rotational stability. As was indicated in the video, injuries to the ACL are rather common and are painful. About 1 in 3,000 individuals will have an ACL injury at some point. And women are actually 2 to 8 times more likely to have this type of injury. And a lot of these injuries are going to require some form of reconstructive surgery. So in 2000, there were approximately 175 surgeries for ACL reconstruction at a cost of around $2 billion. So obviously it's a very common surgery and a very expensive surgery. Surprisingly though, even though it is a common surgery, there's no real consensus in the surgical community on different surgical practices. So there's different graft types used, there's different fixation methods, different pretensions. 2 common graft types are the bone patellar bone, which as you see here, takes a piece of, okay, I'm gonna yell. So, no. I'm not gonna. No, yell, do it. There we go. Okay. Wow. Bone patellar bone. So the bone patellar bone graft takes a piece of bone from the kneecap and a piece of bone from the shin bone and a tendon in between, and that's used as the graft type. The other graft type is a hamstring graft, which takes some of the tendon from the hamstring muscle that attaches it to the shin bone. Also surprising about ACL surgeries is the how common reconstructive surgeries are. About 25% of patients are going to report a looseness or laxity, and a lot of these patients are going to require a second reconstructive surgery. So even though this surgery is very common, it's surprising that there's no real consensus among practices, and it's also surprising the rate of second surgeries that are needed. Part of the complaints of patients, like I said, was laxity and looseness, and this can be related to the collagen organization. So basically, on a microscopic level, these fibers have crimp angles and crimp patterns that relate to the stiffness and tension of the knee. So basically what we're going to look at is how these angles and crimp patterns relate to the overall laxity of the knee. And now we're going to pass it to Alicia, who's going to talk about a research project.
Thanks, Ben. Okay, so our research project is unique because we are going to be looking at both common graft types and how they perform under continuous passive motion, and how those that variable performance relates to the crimping morphology in the grafts. So we're also going to be using OCT, which makes this project unique in its field. So this is the CPM machine that's used commonly by patients after reconstruction surgery, and this is the machine that we're going to be replicating on our legs. So this machine works by the patient straps into the machine and their foot gets placed into a holder, and that moves back and forth and passively moves the knee so that the patient can regain some strength in their leg. And so that is what we're going to be replicating. And our research question is, how do the rates of tension loss differ among the commonly used graft types? And then also, how do the different crimp morphologies of these tissues relate to their variable performance on the biomechanical side? So our hypotheses are that the different graft types will have different tension loss during CPM, and that the microstructural organization of the collagen is related to the rates of tension loss among the grafts. So now we'll have Tina to talk about our methodology.
Alright, so we're going to walk you through our methodology really quick, starting with our experimental setup, followed by our pretest imaging analysis procedures, our mechanical testing, and finally our post-test imaging analysis. So we're going to be taking 10 cadaver legs as well as 20 grafts from the donor bank, half of which will be hamstring and the other half will be patellar tendon. A pair consists of the left and right graft taken from the same body, so we can use one as the control and the other experimental. In addition, we will perform osteotomies on our cadaver legs, which will remove the lower half of the tibia and the upper half of the femur, so we can isolate the part of the knee and the relevant ligaments that we want in our mechanical testing. With that, we will first perform our imaging and mechanical testing on the leg intact, with the ACL absolutely intact, so we can establish a baseline. Afterwards, we'll have our surgeon perform ACL reconstruction with first the hamstring, followed by the patellar tendon. So our pretest imaging analysis consists of two imaging modalities. The first is optical coherence tomography, or OCT. So this can be thought of as an optical ultrasound. It uses infrared light instead of sound waves in order to produce an image. So this is really great because it's indirect, it's non-invasive, it won't destroy the tissue, and it's pretty easy to take. However, this has a pretty low resolution, so we won't be able to get the exact data points that we want. So we will, in addition, we'll be using polarized light microscopy in addition to a staining agent that will allow us to see the collagen fibers and more distinct characteristics of the tissue. But the problem with PLM is that it requires tissue fixation as well as sectioning, so you have to essentially destroy the tissue in order to get the images. So OCT will provide us with the pre-test imaging, so we can do mechanical testing and get images before and after testing. So our mechanical testing consists of using an MTS, or materials testing system, to replicate continuous passive knee motion. This takes the leg from, we're going to take the leg from 20 to 70 degrees of flexion at a rate of 100 degrees per minute for 500 cycles. It's a relatively slow rate, and it's going to be passive, as in you don't use your muscles in order to extend and flex. And then after mechanical testing, we're going to do post-test imaging, which consists of OCT and PLM again, and to get our crimp period, angle, arc length, and base length. So as for our current status of the team, we finalized imaging procedures and we've done preliminary images on crimping and rat ligaments. We've also done preliminary analysis and gotten some crimp angles. We've also bought our tension transducer and we've done preliminary testings as well as calibration of it. We've designed our MTS jig and are in the process of constructing it, and we've also obtained our first cadaver leg, which is pretty cool, and we've obtained another $1,500 grant so we can buy more legs. All right, so now we're going to be Kelly with the imaging analysis.
Okay, so this semester we worked on our imaging method and analyzing and imaging our tissues. It requires multiple steps. We first excise the ligaments and we process and embed in the tissue processor. And we take blocks of paraffin, section them, and we use the microtome to prepare our slides. We then stain the slides and capture images digitally using polarized light microscopy. And this slide shows preliminary results we've obtained. These are 400x rat ligaments. We see an average crimp angle of about 125 degrees. We use ImageJ to take 3 data points and calculate the angle between. Other measurements that we can obtain include the arc length, the base length, and we can approximate the function of that wave. And here's Joey with biomechanics data collection.
All right, so in order to perform the data collection for biomechanics, we needed to use a device known as the arthroscopically embedded force probe. This is a tension transducer, which is placed inside a ligament and is used to measure force as the ligament is stressed. And it allows us to calibrate the sensitivity based on the different forces we're going to apply. In order to calibrate the sensor, we use the preferred calibration method, which entails implanting the transducer into tissue, and measuring force as the weight is increased.